Ahead and start our meeting, call it to order. Welcome to the meeting number 2 of the Budget Review Subcommittee on Health and Human Services. I'd like to thank everybody for their willingness to be on this committee, and those in the audience that your vested interest in it. I can promise you that we will do our very best, provide the best health care for health and human services possible that we can reasonably afford, I hope. So as a reminder, the meeting materials were put online and made available for downloading. And is there any of my colleagues who would like to recognize guests? All right, seeing none. I'm sorry. I miss you, Representative Hebron.
Thank you, Mr. Chairman. I wanted just to take a minute and congratulate you on chairing your first committee hearing today. Glad you're our new chairman.
Thank you. All right, this time we'll have the Secretary call roll, please.
Senator Byrd. Present. Senator Tichenor. Representative Duvall.
Here.
Representative Fleming.
Present.
Representative DJ Johnson.
Present.
Representative Raymer.
Here.
Representative Wilner.
Here.
Representative Wilson.
Here.
Senator Mays Bledsoe. Senator McDaniel. Senator Meredith. Representative Bowling. Representative Bray. Representative Hebron.
Here.
Representative Poor Moser. Representative Petrie. Senator Richardson. And Representative Williams presiding.
Here. Next, we need the approval of the minutes from the June 4th meeting. Do I hear a motion? Second? All in favor say aye. Aye. Pose like sign. Thank you. Those are approved. So today in this meeting, we're kind of focusing on some items that we carved out in the budget, in the last session budget. The 3 items today is long-term care surveyor contracts, where included in the restricted funds, we allowed for $1 million in each fiscal year to support additional contracted services to conduct certification surveys of long-term care facilities and some mandated reports with that. We also allotted in the general fund $20 million in fiscal year 24-25 and $21 million fiscal year 25 and 26 to support workforce and operations of local health departments. And we also, to expand the central laboratory, we authorized bond funds in excess of $36 million. So that's kind of what we're going to talk about today. So our first presentation this morning, we had the Inspector General, Tricia Stewart, Carrie Storms, and Director of Division of Healthcare with the Office of Inspector General, and they're going to provide us with an overview and an update on the status of the long-term care certification surveys, funding provided in the budget bill for personnel to address the backlog in certification surveys. If you would please come to the table and identify yourself for the record, please.
Good morning, Representative Williams. I'm Stephen Stack. I'm the new Secretary for the Cabinet, and since I'm here for some of these presentations, I'll stay with the team.
Perfect.
And I'm Carrie Storms, Director.
Thank you.
And I'm Tricia Stewart, the Inspector General.
Okay, thank you all very much, and you go ahead with your presentation.
Okay, well, we would like to thank you for the opportunity to come forward and provide this overview and update of our long-term care certification survey processes, as well as to address some of the backlog for completion of the surveys that had occurred in the past. As I think everybody knows, the Office of Inspector General is where the Division of Healthcare Agency resides, and that is the state survey agency that is charged with certifying and licensing all levels of healthcare facilities, to include long-term care nursing homes. And the Centers for Medicare and Medicaid, or CMS, mandates specific timeframes for completion of full certification surveys, as well as a tiered process for investigating complaint investigations, which are called abbreviated surveys. And of particular note is the fact that there is a priority 1 level complaint intake that requires the state agency to investigate all allegations that are at a priority 1 within 3 business days of receipt. And just another note on that one, when I talk about the priority 1, those are actually also called immediate jeopardy complaint intakes. So the seriousness of it is that it's alleged that residents are in harm's way or not receiving the care and services, and it has an extreme effect on their welfare, and their health status. So the way that CMS and the State Survey Agency measures compliance with completion of certification surveys is through what CMS has developed and what they utilize. It's a State Performance Standard System measure, or an SPSS. They do release these quarterly as well as at the end of each fiscal year. And it's those at the end of the fiscal year where the majority of the public and where the different states are able to identify the status of, how many surveys they did get completed within that federal fiscal year. In the federal fiscal year of 2024, Kentucky transitioned upward in national standings. We surveyed 101 of Kentucky's 269 long-term care facilities. So they all, 101 received a certification survey. And then those measures also demonstrate the number of outstanding complaints, to include those that are a priority 1 or immediate jeopardy. And during federal fiscal year 2024, the State Survey Agency was able to lower the pending number of outstanding complaints to 1,565. And for that, the State Survey Agency in Kentucky was able to meet that measure for completion of abbreviated surveys. And we're still in fiscal year 2025, which will not end until September the 30th of 25. However, as of July the 7th, 25, the State Survey Agency had lowered the number of outstanding complaints to 695. So this is a chart that compares what I was talking about with the federal fiscal years for completion of full certification or standard surveys. And if you look at this, you'll see in fiscal year 2023, the State Survey Agency was able to complete 28 certification surveys. By the end of fiscal year 2024, the agency had completed 101 surveys. So we had grown very much in that 1 year time. And then current, and this would be the 2025 fiscal year for completion of certification surveys that started on 10/1/24, and the measure here goes through 6/30/25. However, it's important to note that we're only measuring 3/4 of the fiscal year here. So as we're 3/4 done, we currently have completed 186 certification surveys. And this was information that my director, Carrie, gave me earlier. The State Survey Agency, on the current projected plan, hopes to complete at least 40 to 50 more certification surveys before the end of the fiscal year 2025. And this is in regards to the complaints or facility reported incidents, or FRIs, that were not investigated by the fiscal year. I'll make note of what a facility reported incident is. It's a CMS mandated self-report that a facility must make to the State Survey Agency in the event that there's potential or alleged abuse, or there are incidents such as falls that have resulted in serious injury to a resident or residents. And when the state survey agency receives these fries, they are to be triaged and treated the same way complaints are. So they're combined here in our totals. By the end of fiscal year 2023, the Kentucky State Survey Agency had an outstanding number of complaint intakes of 3,028. And during that same time frame, they had 1,033 outstanding priority one or immediate jeopardy complaints that needed to be completed. By the end of fiscal year 2024, the number of total outstanding had significantly lowered to about half. It was at 1,565. The outstanding priority one complaints was at 386. And we're still, as I said, we're still in fiscal year 2025, but as of July the 7th, 2025, the State Survey Agency had reduced the total of outstanding complaints to 695, and we're pleased to say that we have also reduced the total number of outstanding priority one immediate jeopardy intakes is 0. So the state agency did manage to triage, investigate, to ensure that those of more serious nature were taken serious, and the investigations occurred, and we got it down to 0. And I will say, this is another thing the director and I were talking about. She has implemented systems to monitor, to ensure that that number stays at 0. So when the reports are coming forward each quarter, we anticipate that number will stay there. And this is just a list of some of the things that OIG has done to accomplish the success that's demonstrated in this presentation. All of these actions were necessary because for a period of time, the OIG, the State Survey Agency, was stagnant with a low vacancy rate. It was hard to recruit and retain staff, along with having insufficient resources economically as well. Some things that helped were when the governor advocated for and the General Assembly provided salary increases that enabled us to recruit and retain a talented staff. And also when the General Assembly gave the extra $1 million per year to get supplemental contract staff, as well as assistance provided from the federal government. There were just a lot of enhanced resources that we didn't have before that contributed to the bad situation that the OIG's State Survey Agency found themselves in. This administration and the Cabinet for Health and Family Services making efforts or effective use of all of the resources to produce the results that you see here speak for themselves. And I will just make one quick note. One of the bullet points, implemented quality assurance processes, the very last bullet point there. That is another one that is, although all implemented interventions are significant, but it's very significant to point out that there have been quality assurance or improvement measures put in place to monitor, to ensure that the agency continues on an upward trajectory as it is, so that we do become compliant with all required measures by the state and federal governments. Thank you all.
Thank you for your presentation. Do we have any questions from members? I think I saw Senator Tishner first.
Yes,
Go ahead,
thank
please.
you. Thank you guys for your presentation. I just have a question. What designates priority one? What type of cases are we talking about that would be priority one?
Do you want to answer? Go ahead. A priority one is when we receive from a complainant that might be a family member or even from a facility, what I referenced as a FRI, that is alleging that a resident has received harm or has a high potential to receive harm. An example of a high potential would be an elopement, someone who required supervision in a facility, and somehow that resident was able to get out of the facility and elope, and the facility doesn't know where the resident is, that is a priority one. We would go in and investigate, obviously looking at what measures were in place to prevent it from happening, what measures are they implementing, to find the resident and ensure safety, and then systemic measures to ensure it does not happen again with that or any other resident.
Do you mind if I have a follow-up, please? Thank you. So the complaints and fries graph that you had, do you have those numbers that are distinct between how many are complaints and how many are fries? You had them compiled together, but do you happen to have the numbers of cases separated?
No, our systems don't separate those. I think we may have a way that we can do it, but the directive from CMS is that they are treated as a complaint. Our system does identify it to be a fry.
Okay. And those weren't all priority ones.
No, not all.
No, it was
fries.
just all put together. Okay. Okay, thank you.
Senator Burt, you're recognized.
Thank you, Mr. Chairman, and thank you guys for the presentation. I just want to clarify, nursing homes in the state, I'm assuming they undergo an initial survey. And then how frequently are they subject to subsequent surveys? And is this on a rotating basis? Like, do they know, like with Joint Commission, we know when to expect our next survey. Are we on that type of pattern here in the state or no?
No. Well, one reason we're not is because, of the backlog of facilities that we've done a great job of catching them up. But the CMS requires, as well as does the state, requires that the surveys be done within a window or a time frame of 12 months to 15.7 months. So you could receive a survey 12 months from the last time you got one, and the next year your survey might be 15 months from the time you got one. So, and there's criteria we use to help us to determine when we need to get back in.
A follow-up question, sir? Thank you. So, what percentage of homes in the state are currently caught up on their scheduled reviews, surveys?
I don't have a percentage, but I can tell you that what we are doing, we're on target that all nursing homes in Kentucky will have received a full certification survey in either 2024 or 2025. We have a goal of December the 31st, because right now you have some that, we've taken care of, but there were 2019 to 23, no one had been surveyed since 2023. So we're getting all of those pulled into that 24-month time frame first, 24 and 25, by December 31st. Then the next projected goal is by March the 31st, if staffing and everything stays on target in the division, we anticipate that we will have surveys back within the mandated time frame of at least 15.7 or under. Be back on track and meet the measures.
Thank you. May I make a brief statement, sir? I've worked in acute care facilities my entire life, and I've been through many, many Joint Commission surveys, and I have headed many Joint Commission surveys. The value of these surveys is that people know they're coming, they know the rules, and they know to be prepared. If they do not have those incentives, that's a very, very dangerous situation that can ensue. I mean, horrendously dangerous. That we have, last year, 386 level 1 complaints were never addressed. Is that what you said?
Yes, down.
I mean, that's potentially 386 deaths. You understand that? Every one of those people could potentially die from the situation they're in. I so appreciate the work that's been done. I mean, amazing, amazing progress. The fact that we let it get this bad is a shame on the state, and it should not have happened. I was here. I was not aware of it. If this happens again, if we get behind again, somebody needs to make noise. Come to me personally and let me make noise. But you are putting people's lives at risk. And it just cannot happen. These surveys are not just checking boxes.
No, ma'am.
They are real. They actually have a significant impact on the entire framework of the healthcare system that you're in. They cannot be let drop like this. So thank you for your work. If we start getting bad again, I need to know immediately. So thank you.
Thank you.
Thank you, Senator Berg. Next is Senator Meredith. You're recognized.
Thank you, Mr. Chair. And congratulations on the progress that you made. It's quite substantial. I know you're not where you want to be yet, but I can commend you on what you have done. But to Senator Berg's statement, 28 surveys back in 2023, that truly is appalling. That's tragic. That's dereliction of duty. But I'm assuming when you went through your slide showing the steps that have been taken, in your last bullet is implemented quality assurance processes, that's supposed to be the safety valve to ensure that this does not happen again. So can you elaborate a little bit of what those processes are and how that information flows?
Yeah, so Senator, thank you. And then they'll respond additionally to those specific processes. I can't emphasize enough, a big part of this success, in addition to the leadership and the efforts that the staff itself has taken, has been when we had over 10 years of stagnant wages. We had, she said low, but she meant high. We had an enormously high vacancy rate. There just was no workforce to do the work. And then wages went up, of course, because there's a healthcare professional shortage and we need skilled nurses and others who can do these investigations and site visits. So when the salaries were improved, and that's thanks to the legislature and, of course, the governor's advocacy, and you've been aligned on that, and keeping annual wage increases is essential so we don't get back into this situation. And then the extra $1 million a year that the legislature appropriated each of 2 years to get outside contract work, those all were very directly contributory to this, as well as the federal government's help. Now, the federal government's been on a travel restriction, and so we don't get the help from the federal government that we did to get caught up. But we're in a better place now because we're closer, we're much better staffed. And so, yeah, we'll definitely keep you appraised. We never want to be there. I don't think there's any difference of opinion between us and anything you would all say. This is not safe. We never wanted to be here. And yet, despite all the recruiting efforts, when we weren't paying wages that we could recruit, we couldn't get it done. So in addition to that, where I thank the legislature and the governor for your advocacy, then perhaps you can comment on the any of the quality assurance steps that you've put in place.
You want me to?
Yeah,
You
go
just, okay. She kind of helps lead with the quality assurance program a little more than I do. But we did initiate, this was initiated at the end, at kind of the beginning of 2024, I believe. That was right when you came and we started developing the QA program. The program is set up to monitor the numbers of surveys being done. It monitors the system for intakes and sends an alert. The director is always made aware if there is a priority one complaint that comes in, if it's a complaint or a FRI. It has to be. I will say, if it's a FRI, back to what you mentioned, the only difference might be if it's a FRI, we can reach out to that facility and we can gather or ascertain additional information from the facility since they reported it to see if the person's safe or systems are in place. That gives us a 7-day window to go in versus a 3. And we don't always wait the 7, but we do have that. We can triage it and make that determination. But again, the system is set up to send out alerts. Our QAPI team is meeting, I believe, monthly now. We're hoping to get to a quarterly, but for right now, for the past year, they've been meeting at least monthly, going over their schedules, going over this, what's outstanding, and just making sure if anything falls out, they catch one, a survey that the facility was last surveyed in 2020, they catch it here. They've got mechanisms in place to catch that, and then they look at their schedule, their teams, and they get get those pulled in.
Follow up, Mr. Chair, if I could.
please.
Commissioner Stack, I appreciate your comments. I understand. But one of the things that really I'm bewildered by is, I've chaired the Government Contract Review Committee for several years, and we rely a lot on locum tenens coverage for our state healthcare facilities, which is very, very expensive labor. And I don't understand if we can't recruit people because salary scales are not appropriate, but we can afford to buy locum tenens coverage. Shouldn't we be looking at shifting that back to better pay for our people? I think there's a potential savings here. Because, folks, if you haven't sat on government contract review, we're spending tens of millions of dollars for these services because we can't recruit personnel. So is that a challenge maybe you're willing to take on?
Can you help me understand, where are these locums, where are the locums people being paid to work? Can you help me?
At state facilities.
You mean like behavioral health or other facilities? Yeah, I think this has been an industry-wide challenge. I think when you've had the hospitals sit here, they would say very clearly that the staffing costs have gone up dramatically, and because of the shortage of the workforce, what ended up happening is during the pandemic, right, people were just upbidding each other. So there were the same small pool of people, and people upbid the wages, and so they were competing for the same people, and the wages were going up, but no one was necessarily getting more staffing. The staffing was just shuffling around. We would much rather, it's much better to recruit and retain talented people and have a stable workforce. That's how you deliver excellent results, is retention of talented people. So we're aligned in wanting to retain talented people. I don't have off the top of my head our actual vacancy rate right now, but it is way, way better than it was 3-4 years ago. And so our goal is very much to continue to advocate for those reasonable, annual salary increases to keep and we've gone through the classification surveys that the Personnel Cabinet did to try to redo the hiring wages and the hiring rate. Those steps have really helped to solidify our ability to recruit and retain a ready workforce. And so I would agree with you. We would much rather have in-house employed staff. It's lower cost. It's more consistent over time. And that it will be our focus to the best of our ability. I think in general we're in agreement with that statement.
Thank you. Thank you, Mr. Chair.
I think I've got two more questions, and if everybody would help us kind of keep on pace here. Representative Raymer, you're recognized.
Thank you, Mr. Chair. Which I agree with Senator Meredith and Senator Berg about how troubling this is about the surveys not being done. So I'm not going to keep going on that. I mean, we've all said that. And I think you may have said you don't have this information, but what I was wanting to know is how many surveyor positions are currently open. And then I know you all have the goals of getting caught up, but where are we currently at? How many facilities are past that 15-month mark that haven't had surveys right now?
So then the first thing, we can get that number for the vacancy rate.
We'll have to get the second number too.
Yeah, and the second number. Now remember what she was saying though is every facility will have had a visit and a certification survey by the end of this calendar year is the schedule. So everyone should be caught up, and then the goal is to maintain everybody being caught up on a going forward basis starting January 26. I think I've represented that correctly.
March 31st. We have to go one more quarter. We're going to have everybody in 2024 and 2025. So there'll be no outlier who hasn't had a survey since 2020. They'll all be, and then 3 more months to get us into that time frame.
The normal cadence.
0.9 month.
Yep.
Thank you.
Representative Wildner, recognized.
Thank you, Mr. Chairman, and thank you for your presentation. Obviously, a very serious issue, broad agreement on that. I'm so impressed by the progress that you've been able to make. And it's such a stark example of when we put the resources in the right places and there are sufficient resources, we can see progress like this. And so in terms of sustainability of this progress, I'm curious how much of the funding you rely on is from the federal government for your department specifically.
What I understand, it goes into the restricted fund with other federal funds. So I don't have anything that breaks it out exactly what the 1 million did versus the other federal, because it is all together in that restricted fund. But I can tell you that it has enabled us to utilize, we now have 40 contract surveyors since the $1 million was given. And before the General Assembly gave that, there were no contract surveyors. So we do have 40 and still utilizing them. And what's great about that is those contractors come in and they get trained, and many of them decide that they like the job, they like where they're at, and they roll over into the merit system. So it's very, it's a good system for us to have those contractors. And then additionally, we utilize it. We have a contract agency, an outside agency, who sends in full qualified survey teams to do a full facility survey for us.
Quick follow-up.
Yeah, quick, please.
Just again, this being such an urgently important issue, and as the Budget Review Subcommittee for Health, I'm just wondering if there may be changes at the federal level that we may need to, as a subcommittee, figure out how to absorb those shifts. And I hope we can, keep this in mind as we move forward and as this committee makes the budget recommendations, that if there are drop-offs at the federal level, this is not an area where the state should just throw up our hands and say, oh, well, nothing we can do about it. So I hope that we are prepared to make up those shortfalls if they should occur.
Thank you. I thank you all for your presentation today and the work that you put in up to this point. There's a couple of items I think were asked for by members. If you would get those to staff at your convenience, we'd appreciate that.
Will do.
Thank you all. The next item on the agenda this morning is Mike Tuggle, Administrative Branch Manager, Department of Public Health, on the Public Health Transformation Initiative. Funding was provided in budget bill for the Public Health Transformation Initiative. Mike, would you please come to the table and identify yourself for the record, please?
Yeah, it's Mike Tuggle, Department of Public Health, Division of Administration and Financial Management.
Okay, go ahead with your presentation.
Yeah, so I didn't have a paper presentation, but I made some notes here to share. I think it was specifically, the questions were maybe specifically about the financing of public health transformation, so that's kind of my bailiwick in public health.
Yeah.
Do want to remind you, in my 30 years of serving as a public health steward, and many of you I have seen over time on this panel, but one of the most significant pieces of legislation for public health was this public health transformation legislation. So thanks to any and all of you that worked on that and got that passed. Number one, that's been significant. I can say as a 30-year worker in public health. That, of course, is a legislation that has benefited our local county health departments that actually do the work of public health, and that's where you'll find the work being done.
Good.
So thank you all, first of all, for doing that, folks. This is wonderful. 211, 185 through 211, 187 is that legislation that outlines public health transformation. Specifically to the financing of that, it's 211, 186. And let me go down this path with you, because in that 211, 186 chapter of law, it defines a couple of things. It's one's about the funding, how you're to fund public health transformation, but specifically the foundational work of public health transformation. There's three. Let's do this. There's three. I look at it as three legs of public health transformation as far as services and service delivery. There's a foundational arm, which is the mandated services that is required by statute. It's those KRS requirements, the communicable disease mitigation, emergency preparedness and response, the regulation enforcements. Then you have the core services, which were defined by law as the WIC program, the HANDS program, the in-home visitation program, and then, of course, the harm reduction and substance use disorder programs, okay? And then there's a local priorities program. The third leg is the local, meaning the locals, based on needs assessment, can determine if that's something that they need to do and invest in themselves, not taxpayer money. So under the foundation, under the financing side, so under the allocation of funds, that's under the foundational, and that's where the funding is determined. Under the 211-186 law, foundation, we talk about public health transformation, overarching, but what's the funding formula and what does it fund? It funds the foundational component of that, which is the mandated services that are required by our state to make sure it get done. Then under that law is where it talks about how do we determine what is a foundational cost. That law does that. And it determines it based upon the number of workers that are to be devoted to do the delivery and perform the delivery of those foundational services and programs. And that is further defined by that law by saying for every 15,000 population in a county, 3 foundational workers should be delivering the foundational work of the health department. For every range of 1 to 5,000 population above that, additional foundational worker is to be employed by the health department to deliver foundational. So as you can see, progressively going from a 15,000, every county has a basic 3 foundational worker. Even if you've got a 5,000 population or you've got a 15,000, you'll get 3 foundational workers. That's who's doing your foundational work and the number that's doing your foundational work in that county health department. But above that range of 1 to 5,000 above, each range above that 15,000, 1 additional foundational worker is added to perform those mandated core work. So kind of, the framework, you can see what's happening. Public health transformation kind of established a framework, and the framework was said, how many needs to be doing this work, not just randomly. Before that, maybe it was random. We didn't know how many need to be funded to do that work, but now it's very disclosed in 211-186 what that methodology is and how it's to be used. So that's determining then what the cost of foundation. So the statute determines the cost. Now, what makes up that cost? The worker, number one, did, but what's the cost of the worker? It requires us to look at the statewide average cost of doing that. So we have to look back a year and say, what was the cost of doing foundational work a year ago? And the law says take that look and then use that at statewide average cost, not because Louisville Metro may have higher wages and Clinton County, Kentucky may have lower wages based on just where they're located in Kentucky and the demand for work. It says take the average. And that average cost is then determined that every place from Pike to Paducah, from Northern Kentucky to Clinton County, Kenton to Clinton, that average cost is what we say is defined as the funding and that should be determined and used for determining that foundational workers' cost. And as of FY26, that was been determined about $100,000 is what the cost of that worker is. That includes their benefits, their salary. Remember, this is the average cost of the worker. About $100,000 was determined for FY26 to be that value of that foundational worker. In addition to that, that included, it included also that indirect administrative overhead costs of about 15%. So just take that calculation, 100,000 for the worker. Now you have to know how many workers do we have in the public health system, in the local health department system that actually deliver foundational. Based on that population formula, 1,000. So 1,000 of the local health department workforce is devoted by statute to doing that foundational outlay and delivery of foundational work. So 100, so let's go back and do the math. So what you could say from this about if you took the number of workers times the cost of the worker, you look at roughly $100 million is defined by law. What is the cost of foundational work? About $100 million per year. And that, of course, changes year to year as cost drivers obviously influence those costs. Salary cost, operations cost of facilities. But as FY26, approximately $100,000 was the cost of the worker, 1,000 workers, $100 million of cost to deliver. So 211-186 defined both the cost. Now here comes the allocation of any funding made available. So we've determined that the cost is $100 million. Now how do we allocate funding? Well, there's 2 tranches of funding that's available to support this. One is a requirement set by statute that the local health departments and their boards of health or taxing districts must contribute 1.8 cents per $100 of assessed property value. That's a requirement. Never was a requirement before that 1.8 cents had to be required to do foundational work. So now it's an investment that's required by the local government, and the delta between what the local government contributes and the cost we just talked about is in what we asked of the General Assembly to support with the difference. And for FY26, that difference was about $25 million of unfunded need for public health transformation, and that was current year FY26. That was the appropriation provided to this department. I don't have that calculation for you yet for FY27 or 28. As you know, we're in that biennial budget planning and preparation process, so that number has not yet been finalized, but we're working on that as well. But as we know more, we'll share more. So I know that was one of the asks was what does it look like going forward? What's the cost of public health transformation specific to foundational funding going forward? That's something we have not yet finalized, but we are working to do that.
Thank you for that update. Do we have any questions from members? There are no questions. Thank you for your presentation today and the work that you do. And last but not least, we're going to hear from Dr. Stack, the former Commissioner of Public Health. He has now taken on the role of Secretary of the Cabinet. Dr. Stack will provide an update of the Central Laboratory Expansion Project, that bonding that I spoke of earlier, for the funding that was allowed in the budget bill for phase 1 of the project. So if you would please identify your name for the record, and we'll talk more about the Central Lab.
Thanks, Mr. Chair. And let me just, as I can, since I get the opportunities you acknowledge to be the former health commissioner and now the secretary, just the team that has been up here for OIG, and then Mike Tuggle for public health, and now Matt Johnson, who's the director of our laboratory. Many of these people have close to 30 years of government experience, and they're merit employees, many of them, except when they become a division director, then they're non-merit. But just the debt of gratitude that I think we all owe to these career civil servants who just do tireless work to make sure we get the services we need. So I'm just very grateful for them. I'm here now in my capacity as the former health commissioner, and of course this is a big project for the cabinet. Our laboratory, by the time we build the new one, will be about 40 years old. It's past its life expectancy for what is a high-tech, cutting-edge facility that is the only laboratory that does certain things for the entire state of Kentucky. For some of these services, the law requires it, and that's newborn screening. So all 52,000 or so live births in the state are required to have newborn screening provided for inborn errors in metabolism. If you don't catch those diseases within the first few days, they can have irreparable harm if you don't intervene quickly. So we do that by state law, but there's other things like testing for multi-drug resistant organisms, developing tests for evolving pathogens, things that only a high sophisticated lab can do. And then if we have they're concerned about terrorist events, anthrax or ricin or things like that, we are the only state or the lab in the whole state that does testing for bioterrorism substances. And when our lab is not operational for that, we have to ship it to other states. We have reciprocal agreements, but obviously that's not desirable. So this lab is really essential infrastructure for the people of Kentucky. So in 2021, when I was commissioner, it was clear that our lab was aged and had deficiencies that needed to be addressed. We did a feasibility study. We tried to move quickly, but it was just too close. We tried to move too fast, and we couldn't get it in the 22 budget. But then we came back in 24, and thanks to the Capital Planning Board and the legislature, we were approved for Phase 1 funding. And that Phase 1 is well underway. And so we've worked with a firm called Tower Pinkster, who is the general architecture firm. We have some subcontractors they have that specialize in high complexity public health laboratories and the kinds of sophisticated design. This is not just a regular office park building. This is a special boutique building. And so that work is well underway. And so we've already completed, there's 3 phases, A, B, and C. We've completed Phase A. So we are going to build this new structure attached to the current State Central Lab. So it's right over here on Sauer Boulevard across from Sage. And we know where the building will be. We know its orientation. We have programmed the space inside. We know which programs will have how much square feet, where they'll be located relative to each other. All that work has been done. Now we're in Phase B. Phase B is when you start to really drill down on the specific requirements of each of the spaces within the building, when you start to really nail down the costs, what kind of materials you need, how much of them that you need, the engineering requirements. So Phase B is well underway. And then Phase C will be the final stage where you start to get to architectural drawings and things that you can go to market and bid for actual construction work. Phase C is on schedule to be completed by next July. And so the way the legislature funded this, there was Phase 1 funding. And Phase 1 funding provided $36 million, give or take, for the design in the initial start of the project. And then there's a second phase, phase 2 funding, which will be necessary for the construction, and that currently has gone before the Capital Review Board and will be proposed in this next budget. We are on track to have all of the phase C work done by July of 26. So when the funding would become available, we can go to market, bid for contracts for construction. And in an ideal world, we really hope that we'll be able to have the first shovel in the ground next fall. And about 2 years or so after that, the Commonwealth of Kentucky will have a brand new public health laboratory that'll serve it well, I hope, for another 3 or 4 decades. And then the existing state central lab facility. There are other tenants in there who have additional space needs, and so Finance Cabinet will work with the other tenants, and that space will be remediated so that we'll make full use of it. There won't be wasted assets when this project is done. So again, I want to thank the legislature. This is an uncommonly big project, is a capital project for the cabinet. I think it's just of particular importance to the people of Kentucky, and I'm grateful for your investment in our 4.5 million Kentuckians.
Thank you for that update. Do we have any questions, members? Representative Wilner?
Not really a question, but thank you for the presentation. I just want to lift up our former colleague, Dr. Danny Bentley, who really championed this issue. He had arranged a field trip for us last year, and nothing like seeing it with our own eyes to see how immense the need was. So just a shout out to Danny, and appreciate this update on the good work you guys are doing.
Well, thanks, and thanks to Representative Bentley and those of you who came on that tour. I mean, we'll look forward to give you a tour when the brand new facility is built. Of course, I won't be in my role at that point in time, but the next person, I'm sure, will be happy to have you over there.
Any other questions? I'm sorry? Okay, go ahead quickly.
Thank you for your indulgence. I'm honestly asking you this because I'm not sure. 123061. Who up here needs to get updated for measles?
You know, you said 12/30/61. That sounds like a date. Oh, for the birth date. Yeah.
Birth date, yes.
Okay.
I mean, who up here should be revaccinated?
The shortest way that I give this to you all, if you're born before 1957, generally you're considered already exposed and safe. If you have had 2 doses of measles, mumps, rubella vaccine, you're considered immune. So those 2 populations, which capture the vast majority of everybody, are your 2 criteria. So generally 70 or older, or 2 doses of MMR vaccine, you're good. Now, if you have multiple medical problems, or if you're going to travel internationally because measles is spreading even more in certain international countries, then you should probably just go get a booster. And just a single booster, any adult can just go to any pharmacy and probably just get it there. And of course, we always want to encourage you to use your primary care medical home, your family physician, your internist, your OBGYN, your pediatrician. But for those of you who are adults and are unsure, no harm to you to get 1 extra dose. And if you're going to travel internationally, it's recommended by CDC currently that you do that.
Thank you. Leaving the country day after tomorrow.
Go today.
Thank you again for your presentation. And before we adjourn, members, take note that the next scheduled meeting is August the 20th. Now's the time for adjournment. Do I have a motion? Motion. Second? All in favor? Aye. We're adjourned.